Okay, so the next piece of the puzzle are arrhythmias. Arrhythmias are some sort of disruption in the electrical conduction pathway. And there's a variety of severities of arrhythmias. Some are more severe than others. But if the electrical path is somehow interrupted or blocked, that can lead to improper contraction relaxation and ultimately improper blood circulation. So what we're going to use is this tracing up at the top as our normal sinus rhythm. So this is a normal EKG. You'll notice that we have P wave, QRS. So you always know the QRS because that's going to be the larger wave, and then followed by a T wave. I do like putting these in questions. So you might have a question that shows a couple arrhythmias, or maybe a normal with an arrhythmia, and you have to be able to diagnose the arrhythmia. I typically will give you a normal one to reference. So as long as you know what a normal one looks like, we want to look for abnormalities. Some things that you might want to look at are starting with the P wave. Is there a P wave? Is the P wave missing? Are there too many P waves? You also will be looking at, obviously, QRSs, but also the interval. So what we're looking at here is an arrhythmia called a first-degree heart block. So the block means that there's some sort of blockage, not in blood flow, but to the electrical pathway. A lot of times a block will be due to a heart attack. So remember, when there's a heart attack, that death to that cardiac tissue becomes a scar. And the scar might block the electrical transmission. So a first-degree heart block is some sort of blockage. It can often occur around the AV node or anywhere that electrical signal has to travel in order to get down to the ventricles. And you'll notice what happens with the first-degree heart block is you get a prolonged interval between the P and the R or the QRS. So what happened here is it took longer for the signal to get from the atria. Remember, the P wave is the atrial depolarization. It took longer to get to the ventricle where you get the QRS. So this elongation is known as a first-degree heart block. So what we're doing is we're comparing this interval to this very, very short interval here between the P and the QRS. This could progress and get more severe. You could have a second-degree heart block. In this case, the blockage is so severe that in this cycle, or this beat, it never got down to the ventricles. And if the signal doesn't get to the ventricles and you don't get ventricular depolarization, you're going to be missing a QRS. And if you don't have a QRS, you're not going to have a T. Because in order to get a ventricular repolarization, the T wave, you must have had a ventricular depolarization. Notice this is kind of a progressive increase in the interval. So this is fairly normal, maybe a little bit of an elongation here to that PR interval. This next beat, it's a little longer, and then here, there's the P wave, but there's no QRS. And then there's even a third-degree heart block. I'm not going to have you diagnose that one, but that's even more severe. So this slide shows us the two types of heart blocks. What we're looking for is an elongation to the interval and a possible lead up to a dropped beat or a missing QRS. This slide's going to show us some atrial arrhythmias. So we're looking at the P wave. Again, here's the normal sinus rhythm. In this case, we notice that there's multiple P waves leading up to the QRS. So there's kind of some irregularity to the atrial contractions. This can often lead to a slightly more severe arrhythmia known as the atrial fibrillation. So where atrial flutter is too many P waves, and atrial fibrillation is no P waves. So the atria will kind of depolarize a little bit randomly, a very loss of regularity. So notice even this interval here between the QRSs changes a little bit. But the clear thing I want you to notice is that there's no P waves prior to the QRS. So the atria are not depolarizing. And remember, if they don't depolarize, they're not going to contract. Now, this isn't the most severe arrhythmia because you still have ventricular contractions, because you still have these fairly nice QRSs. So the heart will still pump blood. It just might not be as efficient. When you get atrial fibrillation, sometimes the blood sits in that atria a little longer than it should, and that can increase the risk of blood clots that can form. So a lot of times someone with AFib might be put on some type of blood thinner or some type of medication that'll prevent these blood clots forming in the heart. So these are atrial arrhythmias: atrial flutter, too many P waves; atrial fibrillation, no P waves, and some irregularity to these the intervals between QRSs. This slide shows some ventricular arrhythmias. Now, ventricular arrhythmias are always going to be more severe because those are the pumping chambers. Those are the chambers that are most important for getting that blood ejected out of the heart. This arrhythmia is known as ventricular tachycardia. Tachycardia means fast heart. This happens to be the ventricular contractions are fast. If we just use the word tachycardia, that just means a fast heart rate, anything over, say, 100 beats per minute. But this is specifically the ventricles. The ventricles are depolarizing at a high rate. We often call this premature ventricular contractions, or PVCs. It looks like that heart might be pumping a lot of blood, but there's no time to fill. All right, so if the ventricles are contracting too quickly, what happens is they just can't fill effectively, and the heart is not very efficient at pumping blood. This can often lead to an even more severe arrhythmia, which is ventricular fibrillation. So this is where the ventricles start to quiver. And that's due to the kind of lack of full depolarization. So the QRSs have become kind of small, and that's ventricular fibrillation. This is the arrhythmia where you're not going to feel a pulse. A pulse is going to be stretching of arteries whenever you get those ventricular contractions. So you'll be able to feel a pulse, a rapid pulse with the VTach. You'll be able to feel a pulse with AFib, but you won't feel a pulse with ventricular fibrillation. So this arrhythmia could potentially be corrected by using a defibrillator. The problem with ventricular fibrillation is those ventricles are not pumping adequate amounts of blood because they're just kind of quivering. And this arrhythmia could lead to an even more severe arrhythmia we call asystole or flatline. That's when there's no detectable action potentials. There's other arrhythmias. There's a whole bunch of other arrhythmias we're not going to get to. But you hear a lot about bundle branch blocks. Those are often due to heart attacks. And those get a little more tricky, so we're not going to get to those. But hopefully this gives you an idea of how important it is to not just understand an EKG, but to understand first that cardiac conduction path, and therefore understanding what the P wave is, and the QRS, and the T. Okay, next piece of the puzzle. we're going to kind of revisit valves a little bit before we get to the final video of this set is going to really get into the what we call the cardiac cycle. But this is to just kind of better explain our valves. Now that we know a little bit about how the heart works, we can really see when those valves are going to be opened and closed. So we're going to start over here where we have kind of a fully relaxed heart, where the atria are relaxed and the ventricles are relaxed. So during this period in time, that heart can fill. All right, so notice that the AV valves are open, the semilunar valves are closed. In this situation, that heart can bring the blood in and then directly down into the ventricles. All right, so when the AV valves are open, every chamber is relaxed. We call this passive filling. So that heart can fill when it's completely relaxed. Then we're going to enter what's called atrial systole. Atrial systole is kind of, now we're at the start of a new cycle. We're going to contract the atria, all right, so that signal goes from the pacemaker, spreads to the atria depolarize. That's going to add even more blood to the ventricles, all right, so they've been filling here, but now we can add even more blood because we're contracting those atria. Valves are still open here, AV valves, semilunar valves are still closed, but we can kind of top off those ventricles. We can get them full all the way up until, you know, kind of the maximum capacity we want them to be. Then we're going to enter what's known as an isovolumetric period or isovolumetric contraction. That occurs when the ventricles start to contract and they immediately close the AV valves. All right, so that heart's going to produce just enough pressure not to open the semilunar valves yet, but to close the AV valves. And when those AV valves close, we can hear that as that first heart sound. All right. What happens during isovolumetric is the volume in the ventricle stays the same, even though the ventricle's contracting. All right, so how can the volume stay the same? Notice all the valves are closed. If all the valves are closed, no blood can enter a ventricle, no blood can exit a ventricle. So the volume must stay the same. And what that helps us do is really increase the pressure. So notice going from this situation where the ventricles are just starting to contract to this picture where they're really contracting. That pressure now is really high in those ventricles. Remember, this ventricle might get up to 120 millimeters mercury. The right ventricle might get up to like 25 millimeters mercury. So that's this high pressure due to that ventricular contraction, and that high pressure opens the semilunar valves. So notice we have the pulmonary semilunar valve opening and the aortic. And that's going to allow us to eject the blood from the ventricles. All right, we get ventricular ejection. Then notice in this picture, the ventricles are starting to relax. And when those ventricles start to relax again, that pressure in the ventricle goes down. All right, and that's going to close those semilunar valves. All right, AV valves are still closed. All right, they've been closed, but now we're going to close those semilunar valves due to the low pressure. And we're going to hear that sound as the S2 heart sound. All right, so we're kind of piecing together a little more to this heart while it's going through a full cycle. Now, where can we listen to hearts? All right, this is known as auscultation. So auscultation is listening to a bodily sound. In this case, it's the turbulence that is associated with closing of heart valves. All right, so notice in this picture they kind of draw the heart in its proper location. If we were to label these valves, these two would be the AV valves. This would be the mitral valve. This would be the tricuspid valve. These are the semilunar valves, this one being the pulmonary semilunar valve, this one being the aortic valve. Now, when these valves close, it's the turbulence, kind of the reflection of the blood off the valve, that produces the sound. So notice the position that we would place the stethoscope. So that's what this is all about. If we wanted to listen to the individual valves, where would we place the stethoscope? All right, so let's start with the mitral valve. The proper location to listen to that mitral valve is at the 5th intercostal space. All right, so we go to the 5th intercostal space. The sound kind of reverberating from that mitral valve goes this way, and you can pick it up right here. All right, so it's the 5th intercostal space on the left side. If we want to listen to the tricuspid valve, we listen to the 5th intercostal space on the right side of the sternum. Okay? And that should make sense because the mitral valve's on the left, tricuspid valve's on the right. Now, it's the semilunar valves, which are what I would say is counterintuitive. All right, so the pulmonary valve you tend to think is on the right side of the heart, and it is. That's where blood comes from the right ventricle out into the pulmonary trunk. But to listen to the sound, we place the stethoscope left of the sternum at the 2nd intercostal space. And that's where you would be able to hear the pulmonary valve. The aortic valve, because of its position here, the sound emanates off that valve, and we listen on the right of the sternum at the 2nd intercostal space. Okay, so these are the locations where, if you're going into nursing and medicine and part of your job is to listen to the individual valves for any kind of valve anomaly, that's where you would listen. Okay, next topic and final video is going to be on the cardiac cycle. Now this video is going to have all the good stuff. So we're going to start putting everything in order from where we start with that pacemaker all the way until we get to the next cycle. All right, so we call this the cardiac cycle. We're going to put everything we know together. So you may choose to study a little bit before this video, but this video is going to kind of culminate in putting it all together. And then we're going to end up learning about how we might change this cycle. So how can we get the heart to potentially pump more blood or less blood, and what things influence this cardiac cycle.